and Dr. Abdul Sir, Head of the Department, BSPM Dental College and Research Center, Nagpur. The topic for the webinar is Furcation Involvement by Dr. Tirthankar Debnath Sir. I would like to introduce our moderator for today's session, Dr. A.K. Pal Sir, Professor and Head, Department of Periodontics and Implantology, Dr. R. Ahmed Dental College and Hospital, Kolkata. Sir is BDS and MDS from Dr. R. Ahmed Dental College and Hospital, Kolkata, under Kolkata University. He joined West Bengal Services in 1984. At present, Sir is Professor and Head at the Department of Periodontics. Sir is paper setter, external examiner in both undergraduate and postgraduate and PhD exam in different universities. Sir has various published papers in national, international, and state journals. He is a reviewer of various journals, including Armed Forces Medical Journal and Journal of International Clinical Dentistry Research Organization, Journal of IDA West Bengal State Branch. Sir officiated as a Vice President of Indian Society of Periodontology and IDA West Bengal State Branch. Sir is presently President, IDA Kolkata and Suburban Branch, West Bengal. I welcome you, sir.
Thank you, Dr. Modi. Very good morning to everybody.
For today's session.
Am I audible?
Yes, sir.
Okay. So today's webinar speaker is none other than Dr. Tirthankar Debnath. He is Associate Professor in the Department of Periodontics, Dr. R. Ahmed Dental College and Hospital, Kolkata. He is also in charge of the superintendent of this prestigious institute, the oldest institute of Asia. Dr. Debnath did her BDS from Madras University and MDS from West Bengal University of Health Science in Periodontology. Joined in West Bengal Dental Service in 1998. And he is also an author of a book of Ashok's Public Health and Preventive Dentistry. He is the founder member of IDA North Bengal local branch, presently president of that branch also. And he held the post of executive body member, editor, representative of the state IDA from North Bengal local branch also. At present, he is the CDE convener of IDA West Bengal State Branch with his tremendous energetic work in this field in our branch actually. He is the Assistant Organizing Secretary of the 49th IDA West Bengal State Annual Conference, pre-conference chairman in the same 42 National Conference of Indian Society of Periodontology 2017 held in Calcutta. He was the organizing secretary and scientific convener of 55th IDA West Bengal State Annual Conference. He has presented papers and conducted CD programs to various platforms. Colloquium of 2014, 42nd National Conference Indian Society of Periodontology, and published papers in state and national journals also. I am very glad to present Dr. Debnath in this national platform. Dr. Debnath, please.
Thank you very much, sir. I take your blessings first. And thank you all the members of BSPM Dental College, my sir, Dr. Abhay Kolte sir, Dr. Modi, and I have seen the screen, so many eminent sirs have joined, madams have joined. So I dedicate this lecture to my another guru, Professor Dr. T.K. Pal sir. Everybody knows about him. And this live, actually, I should say a broadcast is going on from our IDA West Bengal State Branch office. And I am thankful to the President Dr. Shibram Kormakar and my beloved brother and Secretary and President WBDC Dr. Raju Vishwas, and my brothers, those who are helping me out, all are newly dental surgeons, Dr. Shatra, Dr. Ohik, Dr. Shuja, and many more. And a lot of people in my ISP family of West Bengal chapter. So many have joined my dental college students, my friends, many, and my family. Now, I shall start a topic which is given me as a Furcation. I actually, when we discussed about this, I urged Abhay Kolte sir to give me that topic because I had an opportunity to work with him in many years of Oral Hygiene Day celebrations. Amongst this was the epic one where we did some extraordinary work. What I would say by myself, as because it was a bit long journey for this patient with us, and finally we could do this, which I'll start with the end of that video, and later on after presenting my slides I will come back to that video. So please share that video for a while, just for a few seconds or few minutes. Please do. You can see here my sir, Dr. Abhay Kolte sir. He has done one surgery. That surgery will be slowly will be open to you after this presentation. Now it was a part of the Oral Hygiene Day celebration, as this BSPM Dental College is doing this webinar series for Oral Hygiene Day for this year. It was 31st of July 2019. As because we had 2 days celebrations from ISP West Bengal chapter as well as Indian Dental Association West Bengal State Branch and Department of Periodontology of Arame Dental College and Hospital. So that time Abhay Kolte sir and present President Manfia Pandit Madam, at that time she was the President-elect, she had come to Kolkata, and it is in Army Hospital. So we did one surgery. So sir dedicated to Abhay Kolte sir. Now please go to the PowerPoint presentation. Can you see, sir? Anybody, please?
It's clear, sir.
Okay, fine. Thank you, sir.
Visible.
Now, it was when we discussed about the topic with Dr. Modi and Abhay Kolte sir, then I previously just now I told that I wanted to take this lecture on Furcation. It was given in the flyer that it's Furcation involvement, but intentionally I have kept here only the name Furcation. We will also deal with the Furcation involvement and little bit of Furcation treatment lineup. And as the target audience, as sir told, that the postgraduate students, so I have tried my level best to target that audience. So what is our learning objective today? We think we have the learning objective that what is Furcation, the definition, the terminology, the anatomy, then what is Furcation involvement, its etiology, classification. That part is newly, I have read few articles. I'll just share with you, and one of the latest articles are done by Kolte sir, and another article I have with me. I'll show you later on. Then the diagnosis, in that the clinical probing and radiographs, few new techniques have come, like Ponmintum CT and our perioscope, etc. Clinical features and bit outline of the treatment. Now, Furca means a division. It's very simple. I have kept the few pictures and just lines over there so that people can very easily understand. I can be stopped anytime. Anybody can ask me any question, or later on we'll have the question hour session, as you said. The anatomic area of multi-rooted. The word multi-rooted should be very important, as because the multi-rooted tooth only can have the Furcation area. Tooth where the roots diverge. Very simple. And the terminology is over here. The root complex, it's a portion of a tooth that is located apical to the CEJ. It is divided in two parts, the root trunk and the root cone. It represents the root trunk represents the undivided region of the tooth. The height of the root trunk, the distance between the CEJ and the separation line, the furcation between two cones, and root cone, it's included in the divided region of the root complex. Two or more root cones make the furcated region of the root complex. You can see the picture. The picture is self-explanatory. You can understand very well that this is the root trunk part. I have drawn the CEJ by red line. Just try to depict that one, and you can see the root cone. Both of them makes the root complex. The furcation area is located between the individual root cones. The furcation entrance is the transitional area between the undivided and the divided part of the root. And the furcation fornix is the roof of the furcation. Again, the pictures are given here. You can see the picture like the furcation area. In the multi-rooted three roots of the upper molars and the furcation area of the lower molars, and you can see the fornix and the entrance of the furcation in the third picture. The degree of separation is the angle of separation between two roots. That is again shown by a small red angular drawing in that upper root. And the divergence is the distance between two roots. The distance normally increases in the apical direction. And the coefficient of separation is the length of the root cones in relation to the length of the root complex. Now, why do you learn this terminologies and why do we learn this divergence and cone and fornix? When we'll slowly unfold the slides, we can understand that the instrumentation, the degree, the amount of root trunk present, the amount of divergence, the amount of convergence, all these are important for the furcation getting involved in the periodontal infections. All these are important for the furcation to be treated after the periodontal infections. All these are important to keep the teeth maintained, like giving the supportive therapy after the periodontal infections or the furcation involvement. The average length of the root trunk in the maxillary first molar is 3 mm at the mesial side, 5 mm at the distal side, and 3.5 mm at the vestibular entrance. Now, again, this is again important because the opening of the furcation. Anybody, sir? Anybody? Somebody's audio I heard. Okay. The importance of this distances or important of this root trunk is an average length given. The examination of the furcations for the upper mesial side, upper distal side, and buccal side, obviously from the buccal side. So mesial furcation should be again probed palatally. Distal furcations should be probed buccally. So that will be unfolded in the next slides. The buccal and lingual furcation entrance of the mandibular first molars are located 3 mm and 4 mm apical to the CEJ. Now, as a periodontist, we deal with mm, millimeters. We have very important millimeter, that is 3 mm. We always look for that. And when we deal with millimeters, we should be acquainted with the amount of the tooth and gingiva or periodontium who are having that distance from that CEJ line, which is constant for life. Those things depict, those things gives you the amount of periodontal infection involvement, amount of your prognosis, how do you go about. The mesial furcation located approximately 2/3 towards the palatal aspect of the tooth of the upper molars. That one only I was telling. This is very important thing to understand. The mesial furcation located approximately 2/3 towards the palatal aspect of the tooth, whereas the distal furcation is located in the mid section of the tooth and falls in the intraproximal areas. This may be the reason for the high frequency of distal furcation involvement in the upper molars. And this may be the reason when we look for the mesial furcations of the upper molars, we should probe it palatably. The proximal surfaces of the roots adjacent to the furcation of permanent first molars have plaque harboring concavities, especially the mesiobuccal roots of the upper first molars. They are around 0.3 millimeter concave, and the mesial roots 0.7 millimeters of the mandibular molars. These concavities, they harbor the microorganisms when the subgingival plaque is formed, and that makes the microorganisms to harbor there. And as they are mostly anaerobic, they happily live there, and they produce different degrees of furcations, which we'll know in the classifications, and different subclasses. Few anatomical projections which also hinder the maintenance of the furcation area. And we have something called cervical enamel projections. Based on their proximity to the furcation entrance, they can be grade 1, show a definite change of CEJ level with enamel projecting towards the furcation. Then approach the furcation but not to make contact with it, that is grade 2, and grade 3, extend to the furcation. Now these are important as because when you have an extended element, you will never have that gingiva, the marginal gingiva will not be attached to the enamel surface. Marginal gingiva is always attached to the CEJ onto the cementum by junctional epithelium. Now, if the enamel is projected downwards, the marginal gingiva automatically or the junctional epithelium automatically goes down and makes the furcation area vulnerable for harboring of the bacteria. This is very important picture. Now, this one from the book and this one is from a tooth. I have tried to make you understand. This is a Gracie curate. Then you read this thing, 81% of first maxillary and mandibular molar furcations, the entrance diameter is 1 millimeter or less, and the 58% of the diameter is 0.7 millimeter or less. Considering the width of the conventional curates ranges from 0.7 millimeters to 1.1 millimeters, it's difficult to properly instrument the furcation area in a clinical situation. So from there only we come to that furcation plasty, where we make the furcation area a little bit wider so that instrumentation can be done at the time of treatment as well as at the time of supportive periodontal therapy. Yes, we have many specialized instruments for the furcation area, but still these are the conventional instruments you generally will have in your clinics, and so that you should understand.
Hello.
Sir?
You say now why furcation plasty is done? What is the purpose? Is it because of this reason?
Sir, we'll be coming into the treatment side, sir. It's just, thank you, Dr. Neetu, for the question. We'll be coming into that.
Okay, thank you.
Now, what is furcation involvement? Invasion of the bifurcation and trifurcation of the multi-rooted teeth by periodontal disease. Pathologic resorption of the bone within the furcation. Now, what should be the etiology? Plaque is the generalized etiology. Generally, for everything happens in the periodontal disease due to plaque. Trauma from occlusions, endoperio lesions, vice versa. Local anatomic factors, as we have just discussed. Iatrogenic factors like giving orthodontic brackets or some restorative impingement. Age changes, systemic influences like metabolic changes in case of diabetes, and etc. What can be the classification? Now, these are there in the textbooks, and these only I have put in the slides, but in recent days we have found many more classifications where I can show you the articles and a few things later on. Glickman in 1953 had given the furcation a grade 1, pocket formation into the flute, but intact interradicular bone. That's an incipient lesion. You can see here the grade 1 furcations. Then grade 2, loss of interradicular bone and pocket formation, but not through and through. It's not cul-de-sac. Vertical bone loss may be present. Cul-de-sac means one side it's opening, other side is closed. And these are all dried bone, we are showing it. And the grade 3, where the interradicular bone is totally absent, through and through furcation is getting involved, and the furcation orifice occluded by the gingival tissue. And the grade 4, where the interradicular bone is totally absent and the gingival tissue is also receded apically, so that furcation opening is clinically visible. Now, in 1975, we had that another classification: furcation defect less than 3 mm in depth, furcation defect more than 3 mm in depth but not through and through, and furcation defect grade 3 through and through, and more obviously more than 3 mm. Now, these considerations are only taken, the other two are taken horizontally. We had also a vertical component, as because when there is a apical migration of the junctional epithelium, there is always a pocket formation. So vertical component of a furcation is measured from floor to the furca to the roof of the furca, floor and roof, like where it starts, where it ends. That is Tarnow and Fletcher vertical classification in 1984. Subclass A, where the pocket depth is 1 to 3 mm. Subclass B, where the pocket depth is 4 to 6 mm. Subclass C, where the pocket depth is more than 7 mm. Rather, this would be classified as 1A, 1B, 1C, 2A, 2B, 2C, and 3A, 3B, etc., etc. And these subclassifications are aid in prognosis and obviously in treatment planning. As because if you have 4C, you can definitely understand that prognosis of that tooth is poor. Now, as I was mentioning that there are many classifications later on has come. The articles. Here, one article picture I have shown, which is given in the like this. I'll just this 3-4 articles I have found. These are all written in 2018, 2020, and there they have taken many classifications. Our back program, and in that non-exposed and exposed classifications are there. I have not. Yes, I have just put one example over here, that grade 1, grade 2, grade 3, A, B, C. I would request the PG students or interested people, please go through those articles. One Poltesser has written. I think they must be the persons in Nagpur, the VSPM Dental College. They must have gone through the article, or they must have been the part of this study. So that part classification I have put, and another study I have shown where I found a new thing called exposed and non-exposed. But the gradings are nearly same, 1, 2, 3, 1, 2, 3. Now, how do you go by the clinical probing? We need an explorer. We need a neighbor's probe. That is very important for understanding the degree and the depth and the width of the classification of the involvement of the furcation. All of you must have seen or must have used the neighbor's probe, and mostly they are used for the upper maxillary teeth, as because if you use a horizontal probe, the palatal root itself will stop that probe inside. So you may be juxtaposed by the situation that there is no furcation involvement. That is why you should always use a neighbor's probe, where you can see the entry of the furcations, where you can see even the exit of the furcations also. You may have the involvement of the mesial furcation, the distal the buccal furcation. Also, you may have the involvement of the distal furcation and the buccal furcation. So your clinical eye is these probes and explorers, the periodontal probe, etc. All your extended clinical eye. We always use this, and we have the tactile sensation with this probe, and we should build up the tactile sensation so that we can very well understand whether the furcation is involved or not. Because always when you try to go and check for the furcation, you will be always have a gingival inflammation or gingivitis with that, so that when you put a probe inside, you will be having a amount of blood coming to that area. So you may miss, you may be afraid to go inside, but please go and please try to probe that area, not explode that area, because furcation involved, if it is there, it is there, it is there, it is there. So probing is an area which is already present, exploring an area which is not present. So if you have a catch in the explorer, you find a caries, but if you have a furcation involvement, you have to use a periodontal probe. Next. Now, it's a chart, simply just given some one decision making book from reference hall. In that, to make easily understandable, like when you write a prescription or something, you may not write always the grade 2, grade 3, or you may write, but when you have these depictions of incipient, or you have a class 2 defect, or you have a through and through, you can write like this. This another school of thought. Now, as I was discussing, that maxillary mesial furcations should be probed palatally. This picture will show you that, as because we have seen the anatomical position of the maxillary furcation, and the distal and the buccal furcation, obviously it's from the buccal side. Distal furcation is also from the buccal side, and this is the lower molar furcation examination by a Williams periodontal probe. You can use other probes also which are having more marks, demarcations. Bone sounding or transgingival probing can also be done without, if you do not have a gingival recession, to determine the bone contours, etc. Now here I would like to mention something. In a clinic, you may not have a CBCT, or you may have a CBCT, but generally we always have a IOPA radiograph instrument, IOPA X-ray setup. And for seeing a furcation, please use the parallel cone technique of IOPA. Otherwise, in a angular bisecting angle cone technique, you have always a 5% divergence or 5% convergence of the X-ray, and you may always have a marring that the roots can always obscure the involvement of the furcation, especially for the upper molars. So if you use a parallel cone IOPA technique, this one is nearly good parallel cone also, but there is a bit of superimposition here. There should be no superimposition of the teeth. So in a parallel cone technique, if you find something like an arrow, you can check here, then only you can very well say there is a furcation in, sir. Sometimes superimposition of the parietal root or thick bone may obscure the furcation. Slightest radiographic change in the furcation area should be clinically correlated. Diminished radio density in the furcation area and marked bone loss of a single rooted tooth, and this arrow-shaped radiograph is always tell you that there is a involvement of the furcation. We can use perioscope, we can use the OPG for panoramic view, but OPG again a 25% divergence is there, so should not come to the conclusion without taking a good parallel cone IOPA X-ray. Of course, CBCT will give you a very good depiction of the furcation. Here you can see the bone loss in a marked bone loss in a single rooted tooth, single tooth of a molar. Usually it's a symptomless, maybe sensitive due to gingival recession, or pain may occur if there is a abscess, as we have seen here, and that can be an acute and periodontal, chronic periodontal abscess. And you may have mobility of that tooth, or if you go further, if you have a grade 4 furcation involvement, you generally have a mobility of a tooth. We just discussed the anatomy of the furcation. We have just discussed the involvement of the furcation classification, and we'll just try to give you the outline of the treatment of the furcations. The objectives of the treatment: to eliminate microbial plaque to prevent further attachment loss. Yes, this most important thing is to eliminate the attachment loss. This attachment loss is very important for us, as we all know, that if it is lost, then there is a starting of the periodontal issues or periodontitis. To establish an anatomy of the affected structures that facilitate proper plaque control. Now, I had a question from Dr. Nitu Broto sir. So this, I think this is a one-line answer, maybe the one-line answer to you, that we should establish an anatomy of the affected structure. So we do the furcation plasty and make this little bit rounded so that the marginal gingiva falls on it and it becomes self-cleansable area, and the patient gets motivated to clean that area. For that, we generally do a furcation plasty and to get our plaque not accumulated in that area. Sir can add later on when we have the question session. Again, we have the facility, or we have the liberty to obliterate the furcation defects by various alloplastic grafts, various bone grafts, not only alloplastic, autogenous, so many grafts are there. You all know about that. Then we need to arrest the progression of the disease by that supportive periodontal therapy. We should motivate the patient, and it is seen clinically that if you do a good treatment, a periodontal treatment to your motivated patient, then the patient becomes very serious about his or her teeth, as because he understands the importance of the treatment, and you make them understand that as long as they keep maintaining their oral hygiene, which is very important for us as we are celebrating or observing these oral hygiene lectures, they can have their teeth for their life. So to arrest progression of the disease by motivating, by supportive periodontal therapy, and to restore the compromised dentition by regeneration of the functional attachment apparatus, as well as if needed by some, when you will see the few slides on the treatment, surgical treatments, where you can have to give some restorative measures. Now, what are the difficulties? The root convergence, you have difficulties of root divergence, you have the root trunk length, and the cervical enamel projections, cervical enamel projection, okay, and bifurcation lenses, and etc. Wide divergent roots improves access for the instrumentations. You can see the pictures here. Roots in close proximity makes both traditional and regenerative therapy difficult because of the impaired access and minimal amount of remaining bone between the roots, minimal amount of the remaining. Now, you all know it's very difficult to produce a bone on a bone. And we always try to regenerate. We try to regenerate the periodontal tissues. Now, periodontal tissue regeneration needs a regeneration of the alveolar bone, regeneration of the cementum, regeneration of the connective tissue like periodontal ligament, as well as the epithelium. So different types of tissue structures should be regenerated. And though we have many pluripotent and multipotent cells, but that signaling should be proper, so that any bone graft placed over there should produce regenerative periodontium, which will obliterate the involved furcation. Difficult, but there are many growth factors. There are many procedures where we can induce the growth factors in a bone graft. Alloplastic, allogenic, xenograft, whatever graft you use, you have the advantage of PRF, PRP, so many things. You all have done that. But the anatomical position of the furcations also give you the ability, or at the thing of the prognosis of that your treatment. Now, here are many pictures. These are all extracted teeth. Now, especially these are extracted due to caries. These were not extracted due to periodontal involvements or furcation. That's why these pictures are put intentionally, but to show you the root with short trunk length will be involved early, root with short trunk length. Now you can understand the importance of those definitions or the terminologies what we read over here. Now, if we all know that upper premolar have a bifurcated root near the apex. Now, if for an example, by any means that root tooth get involved in the furcation, that furcation gets involved, we can very well understand that root tooth will fall, because the periodontitis has traveled so apically up to near apex, so that is very difficult for that tooth to stay over there. But if you have a short root trunk length will be involved, but they are more accessible for maintenance. Tooth with long root trunk will be involved later, but be difficult for instrumentation, as I just mentioned. Root length also determines the amount of attachment loss already the tooth has. Long root trunks with short root thus results in poor prognosis. You can see these are all molar, these are all lower molars, these are all upper molars. They are very different, and all the teeth in your mouth are very different. 32 unique characters, unique anatomy. Every anatomy has got a functions and physiology. Now everything defines all these pictures defines your furcation treatment outcome. As we again discussing the anatomical positions and bifurcation ridges, which also affect your amount of involvement of your prognosis outcome. Then we'll just see how the infection travels. As we all know, the picture shows. I'll just show you the pictures now. We're coming to the end of the slides, because we should take another 10 minutes of questioning, as we discussed before. I'll just show you the pictures. What are the treatment outlines, pathways of spread? Now here, automatically one thing comes, that the endoperio lesions, because every time we have seen, if we have a endoperio or especially perioendo lesions, we have in the multi-rooted tooth, and we have the furcation gets involved. You can see this is the primary endo lesion, where from the infection travels to the periodontium. This is a primary perio lesion, where the infection travels from the periodontium to endodontics. Then again, we have secondary perio, secondary elu, we can have the combined lesion. But what we are interested is the involvement of the tooth. Again, this is a pictorial depiction where this accessory root canals directly from the furca area, we can have this involvement of the furcation as well as the apex of the tooth. Next, we have an outline, what we can do. These are all, they have written all the treatment lineups. We just follow, and we should follow scientifically. And if we follow scientifically, we can very well come to a good prognostic value of our treatment. And sometimes we should be aggressive. We should be a little bit of thinking of maintaining the tooth structures. So we just go through, we do a scaling, root planing, odontoplasty, we do odontoplasty, furcationplasty, grade 1. We do all those things with GTR, tunnel preparation, and we do root resection, hemisections, etc. This is outline, and we'll just show you another way of depicting how we can go. This incipient lesions, we can do documentation, and we can just keep recalling. If we have a deep inside, we can go for a GTR. If we have less than 3, then we do a pocket elimination surgery, that is flap. Then we can go a bone grafting more than 3. These all are again your the main surgical your, what is that called, surgical principles should be followed when you do the periodontal surgeries. This is again just to give you an idea what we can do. We can do a bone grafting, we can do a GTR, and we can do something called root amputation, hemisection, and bicuspidization, where we can remove one root and make a tooth as a bicuspid, or remove one root and we make a root as hemisections, and we can put another prosthesis over there. So this is again pictorial depiction where we have osteoplasty, odontoplasty. Then we have a post-operative picture. We see the gingiva, marginal gingiva falls on it. We do a grade 2 where we do osteoplasty, odontoplasty, and if needed, we can go with a GTR membrane bone grafting, again depending upon the principles of flap surgery. Then we can do a grade 3, a tunnel preparation, where we have done this. We can make a furcation via through and through, where the gingiva and the mucosa falls on the furcation area, and that area can be maintained by the tunnel brush so that keratinization happens in this marginal gingiva, so that that furcation area is maintained properly. And in case of endoperioral lesion, E always comes first. We do a root canal treatment. Then we do root separation, involves the sectioning of the root complex, maintenance of all roots. We keep the roots and we separate them. Root resection involves the sectioning and removal of 1 or 2 roots of the multi-rooted tooth. Then we can do bicuspidation, as I just told you. We can keep both the roots and we make them as a bicuspids, rather we make them like a premolars, where we can give a restorations if needed. These are the pictures again where we have done some, we have showing that pictorial schematic representations of root sections, amputations, etc. As I told you that we can remove one root and we can give a prosthesis over that, so that that furcation is treated and the tooth is kept for the occlusal purposes. You can see the pictures over here. These are all textbook pictures, and I'll show one case with a radiograph where we happen to keep that case from 2012, and still till date that patient is with us because his motivation. There's no credit for us. We have just told him, he is a very young chap, so he wanted to keep his tooth because he was advised for extraction at the age of near in 30s. So he just happened to came to us, and we tried to keep his tooth, and it is still there. And fortunately for us, that Avoy Koltesar also had did some surgeries which I started with the video. I'll just try to show you for a while. These are root amputation pictures. These are all textbook pictures. Palatal root amputation, where we give the set, so something which should not hamper the other roots. This is again a chart with the pictures here. Supportive therapy going on, open flap debridement for these root separations, as I said, amputation, one root, amputation, trisection of the roots, and finally, if you cannot help it out, we do the extraction and get those pictures for you. Mandibular hemisections, as we have discussed, this one picture I will show you later on with the restorations over here. You can see bicuspidation, as discussed with this. These are all splints kept so that the regeneration occurs. When you do this, you have to keep the teeth splinted. We also did that. I will show you. This is a pictorial depiction of putting bone graft and GTR membrane. You all know, you all have done that, or will be doing this. The scarting of the GTR, you can see. Grade 2 defect, we have put the GTR, we have put the bone graft here. It's a cul-de-sac. That side is closed, so it's a very easy to keep the bone graft and put a GTR membrane and cover it. And again, the decision making of the root amputation hemisections, where you should have this. Your clinical attachment loss is most important part to decide upon, and your definitely the radiographs, and these days CVCTs are very helpful for this thing. And now slowly we are going into the 3D printing, where you can have your made substances for the furcation involvement by previously maintained, and you just put them inside. Now, this, what I was telling is, sometimes you should be aggressive in your thinking, or you should be, I should not say aggressive, but you should try to maintain and make patient understand that if you do a proper peritoneal therapy and if you try to keep your tooth, you can do that. The effect of peritoneal therapy on survival rate and incidence and complications of multi-rooted teeth in furcation involvement over a period of 5 years. Now, we have done a case from 2012, that is over a period of 9 years it is there. You can find this in all in your internet or all in your library, and you can check that very good conclusions that 83 to 100% observation period and successfully managed by non-surgical and surgical treatments. Of course, there are vertical fractures and endodontic failures are there, frequent complications. It is always there. It will be there because any furcation involvement going for surgery should be endodontically treated. Now, this is a story I will tell you. We have been studying this case from 2012. As you look at the picture, this periodontium or the gingiva won't tell you something. It's a prepared, nothing is there. Then when you look at the X-ray, the OPG, you will see that all the periodontium is weeping. This horizontal bone should have been there. It has gone below down there. The horizontal, the line should have been there. It's gone below. So it's horizontal bone loss. You can see the angular bone losses in those teeth. Again, you can see this tooth, the 3-6, which is all, it's floating there. Now, this was advised for this person to be extracted. Now, this is an IOPA of this tooth, should have been there. The line, now this is here. You can see this, and this, we have done this case, and happily, I can tell you that still it is surviving, and you can see the depth 7 millimeter probing pocket depth. And when we started doing this, as we always told you, that E comes first. So what we did is we did a very good root canal treatment, and we have taken the X-rays with this mark, with this grid, so that we can understand how much bone or how much regeneration we could do. We cannot tell it's a bone or something, but we tried to tell you that it must be a bone. So we have given a alloplastic bone graft, we have given a GTR, and we can show you after 1 year follow-up that after 1 year follow-up, you can see 2012-13 that probing has become a nearly sulcus. Then this patient was actually had come for his aesthetic view, so he was with us, and he always is very motivated. You can see the splint kept after the root canal. You can see the amount of regeneration over here. I would rather emphasize it's a region. You can also see the other teeth where we have also done the periodontal treatment. They are all happily over there. You can see the grid. You can see this bit regeneration. I would obviously tell that, or as we cannot do the histology, we cannot say whether it's a bone or something, but it is the radio opacity says that it should be a bone. Otherwise, it won't stay for these days. Now, this is happy, and with the splint, it is kept over there. But this person was keen for his orthodontic treatment, so that was done. Then we had some problems. But you look at this tooth, it is still there. It is still there with the bone. And later on, this patient had some problem in this, as because of this band, we had some problem in this root. So this was amputated, and it is kept still. This X-ray is taken. You can see the date on November 2020. Here you can see the date. It is November 2020. It is still there, and yes, we could not do the restorative still now because of this pandemic and all these things, but still is there. And this was the person who thanks us for every time. So I also thank you. I'll just show that video for a while and end my this thing. Just that video. Yes. This was again a part from the beginning. I mean, to first jump. You can identify him with this goatee. He was having still there. So this is Coltesser's doing, and as I told you, this is the CBCT for that patient. Now, when we started this, the audience, everyone was against this. Even sir also had some doubt, but we wanted to do it. We did it. You can see that what I said. Ashwitpal sir also was there, TK sir also was there, sir is there, Nimfa madam there, many more. Our principal sir was there, and all members were there from ISPO's Dental chapter, and it was done in the army hospital, that patient only, and we did that. I'll just go fast because it's 1 hour video. Here you can see now, sir will remove out that root. Even you can see his orthodontic retention down. Yeah, it is done. Yes. Then we did some bone grafting with the membrane, I suppose. Yeah, yes. Huh? That's it. We did that amputation. Yeah, this is the part of that tooth, and this is that bone grafting material which is placed inside. Our patient is very motivated, and he always keeps coming, and he is very happy that none of his tooth was extracted, which was advised for extraction, and it has given him an immense psychological boost. That at the first visit, when he was very distressed that he's at the age of 30s, his one tooth will go. Now you could see his picture with so many, with a smart look. So that you can do as a periodontist. You have to preserve a tooth. Yes, sir was showing the applying of the pack should not be on the occlusal side. And finally, what you was telling that in a oral hygiene, if you keep your oral hygiene properly maintained, and it is a duty and motto of a periodontist to maintain your oral hygiene and maintain a tooth and motivate your patients for keeping your teeth intact. Thank you very much, sir. I end here. Sir.
Thank you, Tirtha, for your nice presentation and very informative lecture. I invite questions from those who have joined this webinar.
Yes, comments here.
Which one? How to do the bone sounding and transgingival probing.
Okay, it's applicable.
I think, is it from a postgraduate student or a is very much done in our MD clinical practice or in clinics? I think Dr. Debnath will add something, or
yeah,
it is a very regular work we do.
Regular work we do.
Related to any furcation involvement or
yes.
furcation, any question?
Yes. Under anesthesia, we have to put the.
You must do the bone sounding under anesthesia.
Under anesthesia.
That is the only thing you must maintain. Dr. Modi, we are audible now?
Yes.
Okay. Okay.
Yes, sir.
Yeah, it is. One question is there. Is it necessary to go for GTR? Now, see, GTR is a big concept. GTR is guided tissue regeneration. You cannot just necessitize it for for any bone graft, or you need a necessitization for any bone graft. That concept is because what we want to do is we want to do a regeneration of the tissue. Now, regeneration of epithelium, regeneration of the connective tissue, regeneration of the cementum, regeneration of the alveolar bone. All four types of cells have got some 4 types of growth rates. Epithelium grows faster than the connective tissue. So if you have the growth of the epithelium faster than the connective tissue, you will have a long junction epithelium, which we do not want. We get a repair then. We do not get a regeneration, because we want to regenerate the connective tissue so that we get the intact periodontia. So to stop the ingrowth of the epithelium, we should use a GTR membrane. Now, the bone graft, alloplastic bone graft itself is a stop to the epithelium. The epithelium grows, epithelium stops when it gets a intact, stop contact. Any epithelium, when it gets a contact, it stops. Now the bone graft itself can do that one, but when you use a GTR, you guide that tissue for its growth. And yes, it is always recommended for using a GTR membrane for bone graft. If you have any defect which is not 3-walled, any defect less than 3-walled, you should always go for GTR, because you have to cover the bone graft as well as you have to cover the epithelium.
There is another question. Why cul-de-sacs in more immense?
The anatomy of the upper molars are like that. So when you have a palatal root, you imagine the palatal roots like this. No? So that palatal root is already there. So when you put the neighbor's probe, you will always feel it will go and hit the palatal root, but the Williams probe. And when you give the neighbor's probe, it will go like that. So that may be one of the causes. And when you have 3 roots, you will always have a chunk of the bone. The interradicular bones will be more than the interradicular bones in the lower molars. Lower molars interradicular bone is like that only. No, you have two roots, and interradicular bone is like this. So if one side is involved, the other side always, the furcation goes like that way only. But in case of 3 roots, the furcation has to move this way or this way. So when you have a mesial furcation, you have to see from the palatal side, distal furcation from the distal side, if you put me in the proximal surface.
Actually, if I add something that way, in lower molar, this cul-de-sac appearance is a true one, where it is one side is obstructed by the bone. But in upper one, every time or many a times, we'll see it is a false actually, because that is obstructed by the palatal lobe. If you open the area, then we'll get the actual picture. And that's why it is called more in the maxillary molar. But it is not always true that the maxillary molar has the much more cul-de-sac appearance. It is only the anatomical appearance that gives you the false expressions of the cul-de-sac. I think we'll end it here.
Dr. Modi,
Yes, sir. Yes.
Any comments
So thank you.
on the presentation, please?
Any comments from Dr.
Thank you.
Any comments from Dr. Kolte or
Kolte, sir?
Sir, actually, Kolte sir is busy with NAC inspection.
Okay.
So, yes, sir. So, thank you very much, Dr.
No,
Tirthankar.
one last one message I will give. The furcation area is such an area which is not usually detected by the patient at the very beginning, like the cancer. So the detection of the furcation area is very important in terms of the clinical and the radiological aspect, so that it can be catch early and you can treat early. Because once a grade 1 furcation turns into a grade 2, then again grade 3, then up to grade 4, it is probably impossible thing to do anything for the clinician. So catch them first, So allow the bone to remain there as they were previously. Thank you very much.
Thank you, sir. Thank you, Dr. Debnath, sir, for a very informative and basic lecture on Furcation involvement. I also thank Dr. A.K. Pal, sir, for moderating the session. Thank you very much, sir. Now, our next webinar series or webinar will be on the effective journal club presentation, which will be important for the PG students by Dr. Anurag Sat. So I all request the participants to register for the session. I would like to share the certificates on behalf of BSPM Dental College and Department of Perio. I hand over the certificate of thank you, sir, for your guidance.
Thank you so much. Thank you, sir. Thank you so much.
Also hand over the certificate to Dr. A.K. Pal, sir, for moderating the session. Thank you, sir.
Thank you.
Much.
Thank you very much.
Okay. So we will end the session here.
Yes, we can say, we can end it. Thank you very much.
Thank you all the participants.
Wonderful.